Good afternoon, everyone. Welcome, welcome to our afternoon lecture for MacLean Ethics. My name is Kimberly Martin. I'm a nurse practitioner here in palliative care at University of Chicago, and I have the pleasure of introducing our next speaker, Dr. Timothy Elder. Timothy Elder is a postdoctoral research associate at Dartmouth Institute for Health Policy and Clinical Practice at the Geisel School of Medicine. A sociologist of medicine, his research examines how professional specialization and rationalization shape the practice of care for the dying. His ethnographic and interview-based work with hospice and palliative medicine clinicians explores how practitioners sustain moral orientation and purpose in the face of medicine's intrinsic limits, where cure is no longer possible and meaning itself becomes a site of work. Timothy's book project, Winning at a Losing Game, Medicine's Challenge in Caring for the Dying, traces how the very forces that have made modern medicine powerful, technical expertise, specialization, and bureaucratic organization have also obscured its ethical horizon. His concept of hewing, developed in qualitative sociology, describes the fragile alignment clinicians achieve with patients and families as they seek a good death within a system organized around prolonging life. Timothy received his PhD in sociology from the University of Chicago. His writing has appeared in Poetics, a journal of empirical research on culture and qualitative sociology. Across his work, he investigates how professionals confront the boundary between what can be done and what should be done, and how care, even under conditions of futility, becomes a form of ethical endurance. Welcome, Timothy Elder.
Thank you, everyone. One moment while I sort out some technical difficulties here. Go full screen. Some things in the way. My worst fear of presenting has been realized, where I've just my worst fear has been realized, which is I've demonstrated to you that you're not in safe hands yet, which is ultimately the number one thing you need to do as a presenter, is instill a sincere sense of confidence. But I will repair that immediately by saying thank you so much for having me here. I want to thank Kim for that very lovely introduction, for Haley and Ale, and for the MacLean Center for their work in coordinating me getting here and for inviting me. And before I jump into the talk, I want to provide a few caveats, perhaps to temper your expectations. And the first caveat is that I'm a sociologist, and though I work at a school of medicine and in a department that specializes in health policy and clinical research, that I'm still distinctly of a social scientific mindset. And here's a slide that shows you some of the foundational and contemporary figures in sociology. You might see a familiar face there with Alex Tate, who I was very happy to see presented here recently. I think that this talk will be an excellent coda to her talk. But I present this, I simply give this caveat to say that I might not perfectly conform to your ideas about how research is conducted and presented. And the second caveat I want to provide is that today I'm going to be talking a lot about hospice and palliative medicine. And here you can see some of the foundational figures in hospice and palliative medicine, as well as some of the contemporary leaders, Balfour Mount and Cicely Saunders in particular up there. And so at times the talk might seem slightly hagiographic, that I'm idealizing this particular specialty in medicine. Pardon? Oh, I need to share all of it. Okay, is that good? Thank you. It might appear hagiographic, that I'm idealizing this specialty because of my own partiality to it. And though I am partial to hospice and palliative medicine, as I have many friends in it, many of whom are here today, but that ultimately by the end of the talk, I want to instill in you the understanding that the features of hospice and palliative medicine that I'm going to be talking about today, I think are indicative of some of the solutions to regular problems that happen in medicine. And that the reason that hospice and palliative medicine is unique are for structural reasons. And so if other specialties in medicine had a similar set of structural characteristics, they too would behave in a similar way. This is to say that there's nothing unique about the clinicians in hospice and palliative medicine beyond their own individuality and personal uniqueness, but that there's a structural affordance that allows them to get their work done in the way that they get it done. And so with the caveats out of, well, there's one more caveat, which is I'm talking about, in particular, inpatient practice in the United States. I'm not familiar with international contexts, and I think that the inpatient setting is the most decisive and acute environment for the dynamics that I'm going to be talking about today. And before getting into the body of the talk, I want to begin with the end. And I want to do that to give you a clear summary of the arc of the argument that I'm going to be presenting today, as well as the conclusion. Just in case you want to leave early, at least you'll be able to tell your colleagues what the talk was about, right? And today what I'm going to be doing is I'm going to be arguing that medicine has adopted a scientific rationalism in its production of knowledge, in its mode of training, and in its organization of practice. And why this is the case, why this specific epistemic organization for medicine has come about, I'm going to leave other scholars to argue for, though I'll give you a sort of a brief synopsis about how this is realized in medicine. And I mean something very specific by rationality, which I will return to in a moment. But secondly, the implications for clinical practice is that it's organized on the basis of a rational model, in which data about patients and their illnesses or injuries are correlated to decision heuristics that seek to indicate a clear treatment pathway forward. The foundational assumption of this paradigm for organizing care is that patients' illnesses or injuries are vulnerable to being cured, or patients' lives prolonged, ultimately. And fourth, when this assumption is not satisfied, when cure and life prolongation is not available, that the modality by which clinical practice is organized breaks down, and the coordination of care consequently fractures. And in technical specialties in particular, clinicians retreat back to their specific areas of expertise, and patient care consequently further fractures. And I'm going to make the argument that hospice and palliative medicine reorients care back to preferences and achievable goals that are established in conversation with patients. And that this is a paradigm by which some of the fundamental problems that medicine produces in the care of the seriously and terminally ill can be resolved. So ultimately, sort of the tag of this argument is that the rationality that gives medicine its power also narrows its sense of what is good in terms of an outcome. And the hospice and palliative medicine is able to reopen it. So a moment ago, I mentioned that I mean something very specific by rationality. And to give you a sense of what I mean, I'm going to appeal to one of the foundational figures in sociology, who is Max Weber, pictured here, looking very stern. And Max Weber studied the rise of the Prussian bureaucracy, essentially, and its implications on productivity in the state. And he described that to achieve sort of a more profound control over the state, that the bureaucracy adopted this rational system of organization. And by rationalization, he means several things. The first is making practices homogenous by creating anonymous standards which people can orient to. Now, essentially what this does is this is achieved by creating codified rules that people can orient to. So thus, personal discretion in one's work is reduced because one can orient to an anonymous standard to direct their work. Secondly, work was organized on the basis of maximizing efficiency, which is to say, getting the maximum output from a fixed set of inputs. And lastly, a reliance upon expert, which is to say abstract knowledge, and impersonal or impartial judgment. Now, in a medical context, you can think of this as when a clinician orders lab tests or follows a treatment guideline, they're relying on knowledge that's produced and standardized, that's validated far upstream from local clinical practice. And through population studies, statistical inference, and standardized trials. And that knowledge is impersonal in the sense that it's meant to apply to anyone, anywhere, given the same parameters. In that sense, expertise itself becomes a kind of abstraction, a way of acting as if the individual case can be read through a general rule. And I think Weber neatly summarizes this when he says that one can, in principle, master all things through calculability, or by calculation, rather. And I want you to sort of keep that quote in mind as we move forward. And I think that when we look at the arc of development in medicine, that we can appropriately say that medicine has followed a similar paradigm of rationalization. Paul Starr, in his magnum opus, The Social Transformation of American Medicine, describes how the medical profession consolidated its authority in the United States by standardizing medical curricula across the United States. At the beginning of the 20th century, the Flexner Report was produced, and medical education was standardized both in terms of what was taught, but also entrance exams and certification exams to graduate. And the AMA achieved its final goal of creating uniform standards of credentialing for clinicians that was enforced by the state. And Donald Light, in his framework about countervailing powers, I think puts a finer point on this, where he describes the consolidation of medical practice into hospitals, into large organizations, and where practice was in part standardized for a number of reasons. Some of them are rather obvious, where there are the demands for a standard mechanism of accounting for third-party payers, right? You need a mechanism by which you can determine what you've done so it can be paid for by a third party. And there's also, to some degree, a story of the rise of malpractice law here as well, to help to describe the standardization of practice, where one needs to be able to describe whether or not they achieved what a reasonable clinician would do in this particular case to preserve them from the argument that they sort of failed, that they were committing malpractice, for lack of a better word. And I think that this rationalization of medicine can be seen in a number of ways, both in how we talk about illness, particularly patients who have cancer and their fight with cancer, the struggle that they endure, the warrior mentality that they adopt, but also in the major marketing strategies that healthcare institutions adopt. So for example, you have a bus with Northwestern's neurology department describing how on a relentless pursuit of better neurology care. And of course, I'm not gonna be critical of people getting better neurology care. That's, I think, good. But it begins to indicate sort of this paradigm and this mindset. And I think that a more vivid example is from the University of Chicago, where we have this advertisement here which describes that sickness is relentless, so are we, smarter than heart disease, tougher than cancer. And we see the realization of this kind of rationalization in both a technological imperative, the need to innovate, but also in the treatment imperative, that need to provide a life-prolonging or curative therapy to individuals. And despite these changes to medicine, this rationalization, the rise of this technological imperative, of the treatment imperative, one thing has remained constant, which is the enduring importance of the patient-clinician relationship. And Stefan Timmermans, a sociologist at UCLA, I think makes this point quite clearly, where he describes that despite these fundamental changes in healthcare delivery in the United States, the patient-clinician relationship endures as the fulcrum upon which healthcare delivery pivots. And he describes this in quite vivid terms, where he describes that, without patients vocalizing what is wrong and clinicians translating the voice of the life world into the voice of medicine, healthcare as we know it would not exist. And so he's saying that not only is this relationship important, but the specific content of the social interaction and the intervention of talk in particular as a modality of organizing medical care. So, but despite the enduring importance of the patient-clinician relationship, one thing has changed beyond the rationalization of medicine, but the rise in a very sophisticated division of labor within clinical practice. That means that it's not simply the clinician relationship, that is important for healthcare delivery or foundational to it, but the network of clinicians that are called upon to render both their advice and expertise in the care of the seriously and terminally ill. Here I have a dendrogram showing the full breadth of specialties in, as according to the American Board of Medical Specialties. So this is allopathic medicine. And there's fully some 88 different subspecialties across 20 different primary areas. And in a conversation I just had with Brian, apparently I could add a further layer of subspecialization. And these different areas of medicine are defined by a narrow expertise in a type of pathology, such as oncology, or an organ system such as cardiology, or a modality by which the intervention is made, such as the surgical specialties. And this isn't just a helpful addition that we can sit on top of healthcare delivery, but is actually now foundational to how healthcare delivery occurs. This is Hai-Young Oh, who's a sociologist at UC Denver who has done a lot of work on this. And she writes that advances in biomedical technologies and the increased specialization of the medical profession have made collaboration among specialty physicians integral to care delivery. Now, in part, this is the result of the rise of this technological imperative. Ever more sophisticated technologies are invented that require a non-negligible amount of training and familiarity to have facility with, essentially. And it means that you're not going to be able to be a specialist in all things, because it requires some significant time to become conversant with some specific area of practice. So we've arrived at essentially the heart of the matter, which is to say that medicine has become quite effective in preventing premature death by rationalizing its practice through adopting these standard practices, by essentially adopting an algorithmic process by which knowledge is produced and applied to patients' cases and treatments rendered to them. But what endures as the ultimate limit of medicine's efficacy is death, right? It might be overstatement to some degree, but I think that all patients are terminally ill patients in waiting, essentially, right? Because death is permanent and irreversible and universal and will always occur. And so essentially, what's going to organize the rest of this talk is how medicine confronts this ultimate limit of death and how it's realized in practice. What are the problems it produces and how are they resolved? At least, what is the example that hospice and palliative medicine has to offer in terms of how it can be resolved? And so before I move forward, I would like to offer the opportunity to take any questions that you might have, because I spoke quickly and I presented a lot of stuff. And so I would invite questions if you have some burning desire to know something more. So. I have been perfectly coherent and articulate, and everybody's on board. Nobody disagrees. Well, if you do have a question, please raise your hand and I will be happily take it. So, what I'm going to do next is I'm going to walk you through a series of papers that I've written. And I'm not just simply doing this to provide an advertisement for my work, but what I'm going to be doing is providing insight into how I've approached this question of how medicine confronts its limit, how the problems are produced and how they're resolved. And I'm going to be layering one on top of the other a set of sort of the things that I found, and they're all going to build upon one another. And so I began this investigation with my dissertation work. And I'm not going to linger too long on this. I'm going to provide you sort of what data I collected, and then we're going to move on to the more substantive stuff, because though I'm proud of my dissertation work, I've significantly refined my insights since completing it. And so for my dissertation, I completed a number of in-depth interviews as well as ethnographic observations, 78 respondents for the interviews across 46 different institutions in 19 states, and they were all contacted remotely or via email, and I interviewed them remotely. This was at the height of the pandemic, so I was happy to get as many interviews as I could. And the content of these interviews focused on how people get their work done, what they find frustrating about their work, and it was primarily sampling clinicians that work in specialties that deal with patients who are seriously or terminally ill, and hospice and palliative medicine in particular. As I mentioned, I was doing this during the pandemic, and so finally, when the public health environment afforded it, I was able to do observations with the palliative care team at a large Midwestern academically affiliated teaching hospital, where I conducted about 100 hours of observations over a year. And so, as I said, I'm not going to linger on the dissertation because I have many more interesting things to describe that came from this set of data. So, but what I want to begin with is the particular circumstances that call for the inclusion of a hospice and palliative medicine clinician in a patient's case, and ultimately what the problem of rationality in medicine, or what is the problem that rationality in medicine produces for the terminally ill and the seriously ill to some degree. And so hospice and palliative medicine has two domains of expertise: pain and symptom management and goals of care. Pain and symptom management is a fairly straightforward domain of expertise that includes addressing the full gamut of symptoms that result from serious illness. Goals of care is slightly different. It's also called complex decision making and involves clinicians helping both, palliative care clinicians helping both their colleagues and their patients decide what to do. Essentially, what's the least bad decision amongst all these bad decisions to choose from? To some degree, that's how some of the respondents described it. But what occurred to me doing my interviews and researching medicine is it seemed very odd to me that a clinician who has a longitudinal relationship with a patient, at the moment that the most decisive decisions have to be made, call in a relative stranger to help out with that. I mean, that seemed a little bit odd to me. And oftentimes we think about, I think, goals of care in terms of uncertainty. About how to resolve problems of goals of care, one has to reduce the amount of uncertainty in the case. And uncertainty is typically thought of as a deficit. It's been written about in many different ways. It's a foundational sort of topic in the sociology of medicine. But uncertainty is ultimately about deficits, either in knowledge or experience. One doesn't know enough, or one hasn't seen enough to be able to decide what to do. But I think instead we should think about what is the problem that rationality produces. In particular, how do the heuristics and processes in medicine used to indicate what is the right thing to do, the right therapy or therapies, the right decision, produce inexactness when the foundational assumption of cure or longevity are not met? You remember earlier I described that clinical practice as sort of this ideal of abiding by clinical data derived from the patient being matched to heuristics and standards of care to get to a decision pathway. And essentially, clinical ambiguity is the term that I use to describe when these standards, instead of producing a clear decision, a clear path forward, produce many different kinds of paths forward. I think this is best described in terms of frequently clinical practice is about taking a set of descriptions and getting to a recommendation, a set of claims about what is to about what should be done. And in an ambiguous situation, that link between what is and what should be done breaks down, or what is and what ought to be done breaks down. Now, I want to appeal to some of the things that my respondents said to help make this point. Dr. McIntyre, a palliative care attending, describes when we know what the path forward is, like if someone has a urine infection, generally you're going to give antibiotics and move on. You're not going to question what are the goals of care. Hospice and palliative medicine clinicians note that, and the end quote, hospice and palliative medicine clinicians note that such a paradigm is not in itself an inappropriate means of organizing care. For example, Dr. Pierce, another palliative care attending, continues to describe that a routinized set of procedures help to govern patient care. And I quote, which means if you were to show up at a hospital in a state of extremis, the automation of clinical care waterfalls down a series of algorithms and decision trees such that you will, by default, receive care to preserve your life, end quote. Now, this process is dominant in medicine because it is effective for so many patients. The respondent describes that, and I quote, for the majority of us, that's fantastic. That's what has mitigated early death for a significant proportion of the population, end quote. The problem with this framework arises when the algorithmic process is unguided by the clear goals of cure or longevity. At such a point, the routines of medicine continue. And and quote, when you have a hammer, everything looks like a nail, end quote. So in the care of seriously ill patients, when the established routines that effectively organize patient care fail, clinicians ask HPM to consult on the case to engage patients in goals of care. Dr. McIntyre describes again, and I quote, when someone gets so medically sick and doctors start saying, what are the goals of care? That is actually code, and they don't even realize it. They've hit an uncertain situation, and there's several paths before them, and they don't know which one is best because we're no longer on an algorithm of this is the best answer. And I guess I should have edited when he said uncertain there, because it kind of undermines my claim about that we should talk about ambiguity instead. But I think that the claim holds here. And so ambiguity arises in patient care as a result of the mismatch of standard practices to the situations that patients at the end of life in particular face. And so hospice and palliative medicine is called upon to deal with cases that have this situation of clinical ambiguity. And I wanted to try to specify what is the process that they adopt to resolve this clinical ambiguity. And I actually have a paper for that, luckily. And this one's forthcoming in Qualitative Sociology, so you'll be able to read it, I believe, in early 2026. But essentially in this paper, I tried to clearly specify what is the process that they use to resolve these ambiguous situations. And particularly, what are the sort of criteria of success that these clinicians use to guide their practice, particularly considering that they're operating in a professional milieu, they're dealing with cases that are typically considered failures of medical intervention, particularly by their colleagues. And they say this essentially, all of my patients die most of the time, right? And they also, but they're able to find success or good outcomes in what otherwise would be seen as a kind of an unmitigated failure of medical intervention. And they're doing all of this while working in a professional milieu where their colleagues do not share this perspective that you can find success in the death of a patient, essentially. And I think that the answer to what success looks like for this particular specialty of medicine is fundamentally different from other areas of medicine. And I think it's well captured by this quote, where the respondent said, many physicians ask the question, what can I do? And I think palliative care asks, what should we do? And I think that this is the key distinction, is rather than focusing upon outcomes, they focus upon processes, because the outcomes that are going to be experienced they look like failure. They look like the death of a patient, essentially. And I think that this is, I tried to distill this into this figure here. So the process that these clinicians use to resolve ambiguous clinical situations to achieve success on their terms is by first translating information to establish a shared basis of decision making and between these different stakeholders, being sensitive to the repertoires that these different stakeholders use to understand and talk about illness and treatment. You'll remember earlier what the quote from Stephen Timmermans about the translation of the voice of the life world and the voice of medicine. And we're going to return to that in just a moment. And secondly, what they do is they establish a set of preferences. And again, there's a lot of promissory notes here, but we're going to return to preferences again in one moment. Essentially attempting to establish the basis upon which further action can be taken by reorienting clinicians to the subjectivity of the patient. And finally, they try to keep everybody oriented to that same shared set of goals that they established by interacting with the patient. But a key feature of this conversation, the talking that they do with clinicians and patients, is this process of translation. And so I want to linger there next. Well, I should also say that how I see this, again, sort of visually, is hospice and palliative medicine trying to push their colleagues back towards an emphasis on goals of care instead of falling back to their narrow areas of specialization when the care coordination breaks down, essentially. And so to address this matter of translation between clinicians and patients that hospice and palliative medicine conducts, I want to use another quote from another respondents, because they emphasize this, which is that one of the things they talk about with trainees is, did we have a good conversation about goals, and did we make progress on symptoms? Essentially emphasizing this intervention of talk as being integral to the practice of palliative medicine. And luckily I have a paper for that as well, again. And this is where I think some of the more kind of heterodox opinion or ideas are going to come out, and I'm particularly excited about getting everyone's impression on them. But I think that the paradigm that we can use to understand this is that there are these two different ways of talking in medicine, or at least in these kinds of contexts that we're dealing with here. Stephen Timmermans talks about the voice of the life world and the voice of medicine. I talk about the discourse of data and ordinary talk. And by discourse of data, I mean the kind of language that clinicians use to describe illness and injury and the treatments that are available. And it's typically impartial, and it's based upon objective judgment, and it uses anonymous data to inform decision making. But patients bring to clinics and hospitals a set of concerns that are expressed in a multivocal and idiosyncratic vernacular that doesn't conform to a more rigid idea or this more rigid repertoire of talk, the discourse of data. And to bridge these two ways of thinking and talking about serious illness and medical treatment, I think hospice and palliative medicine clinicians adopt this unique way of bridging these two vernaculars, these two repertoires. And I call this the talk of values. And essentially what they're trying to do here is bridge these two ways of talking by forming values from the idiosyncratic preferences that patients express having that conform to the normative commitments of clinicians. And in this process, I guess let me just stop real quick. Are there any questions at this point? Okay, cool. What I'm working towards here is trying to clearly specify what the process is by which these kinds of clinicians resolve these ambiguous situations. And I've tried to enumerate this process by saying that the first thing they do is translate between clinicians and the patients that they care for, because they're separated by these distinct ways of approaching thinking about and talking about serious illness and medical treatment. And this unique repertoire of talk, this talk of values, helps to achieve that translation. And the second thing they do is they try to communicate to their colleagues in other areas of medicine a set of shared and achievable goals derived from the preferences that patients express having. And this process I call hewing. And the third part of the process of resolving these clinically ambiguous situations is keeping everybody oriented to the same goals. So we're in the middle process right now. And now hewing is this metaphor from woodworking, essentially. And it has two separate kinds of meanings. When you hew a plane of wood, you're creating a flat surface by which you can build a structure, right? But hewing also means abiding closely by a principle, right? And so I think that this appropriately describes this process where in interacting with patients, hospice and palliative medicine clinicians are able to craft the values that patients have, the preferences that patients have. And I'm going to get to the distinction between those two in a moment. And then they try to encourage their clinicians to closely abide by those preferences. So rather than thinking of values as things patients have, things that you discover in conversation, I think that they should be thought of as things that are constituted in interaction between clinicians and patients. Now, values are hewed from stated preferences. This is to say, when you talk about values, you're talking simply about those constellation of preferences that patients have. They're not things in and of themselves that patients have themselves. They're simply a medium by which you describe them. And in the course of crafting these preferences, these values, hospice and palliative medicine clinicians seek to avoid inconsequentially distinct alternatives. A respondent described this in terms of an analogy to taking care of their kids, where in the morning, the kid's gonna have cereal, but to give this veneer of autonomy, they say, do you want the red bowl or the yellow bowl? But you're still having cereal, right? And that's the sense in which I mean inconsequentially distinct, right? Do you want this therapy that will extend your life 6 months, or do you want that therapy that will extend your life 6 months? Or you can think of other examples yourselves. So I want to make this point very clearly, and I want to linger here, which is that I don't think that we should think about values causing preferences, but instead that we should think of preferences causing values. And this distinction that I'm trying to draw on here is one that has been recently noted in cognitive science and sociological theory, where rather than abstracted interest in hypothetical states, values should be understood as substantial material engagements rather than these abstract principles. The term preferences here is meant to capture that unmediated attention to goals in a way that avoids the abstraction associated with values, particularly in the clinical setting. So as values are described by clinicians, they function more as justifications or rationales for desires, reasons for wanting, rather than the intrinsic desires themselves, the wantings. Right? In a way, this actually, I'll skip that point. I was about to bring up Marx, but we can avoid Marx for now. So I want to give a little bit more sort of vivid color to what I mean by values causing preferences and preferences causing values. And I'll do that by appealing to something that one of the respondents said. And they weren't speaking of anything in of any one case in particular, but rather of the cases that they deal with in general. And a palliative care attending describes that, we, palliative care, have the gift of language, at least sometimes. And that in the course of resolving ambiguous clinical situations, they instruct that, and I quote, the first thing you should be doing is actually trying to understand who a person is and what's important to them. And they continue by saying, a lot of times what matters most to somebody might be completely different from what everybody thinks it is. They may think, oh, it's most important to this person to continue chemotherapy no matter what. Well, that might not actually be the case. The thing that may be most important to them is getting to their granddaughter's birthday or their wedding or something. And then saying, okay, well, what treatments are on the table? What does life look like based on those things? End quote. Now, I think that this quote is meant to demonstrate that hospice and palliative medicine clarifies that substantial engagement and that substantial material engagement in promoting certain states of affairs, which can help reorient everyone in patient care back to a set of shared goals. Now, you can imagine a clinician after hearing that this patient is interested in getting at a specific event in their family's life. You can imagine that they might describe that this patient values family, right? I think that this is a fairly uncontroversial claim. But the distinction that I'm trying to draw between values and preferences is that when you say the patient values family, this doesn't indicate any kind of material engagement in the world. And most importantly, it doesn't give you any clear, achievable objective. How do you promote someone's value of family? Don't quite know. But you can promote someone's objective of getting to a particular event, right? Now, I don't want my presentation of how clinical ambiguity is resolved by these kinds of clinicians to seem like it's straightforward or that this process is uncomplicated. And I want to linger on this next anecdote that a respondent shared with me, which was involved a bone marrow transplant patient who had experienced a number of pretty despairing complications as a result of their illness and were no longer able to make decisions for themselves. And so their wife was the primary decision maker on the case. And the palliative care team was asked to go and talk to the patient's wife by the transplant team. And apparently the transplant team were saying to this wife, you could go home with palliative care, essentially saying you could go home with outpatient palliative care because they wanted to get home. They were kind of sick of being in the hospital. They wanted to be with the patient's family because they knew things were not going very well. And so transplant team says, well, go home with outpatient palliative care to deal with your pain. And the palliative care clinician goes to the wife and discovers in his words that the situation was insane. The person was on high flow nasal cannula and was completely unsustainable outside of the hospital, essentially saying that this patient is not going to be able to get home just with an outpatient palliative care follow-up. They're going to need to transition to hospice if they're going to want to achieve this goal of getting home and having the opportunity to see all their family members at home. And so after talking to the wife for a substantial amount of time, the wife agrees, okay, we'll do hospice. So later, the hospice and palliative medicine clinician calls the transplant team and says, I quote, can you put in the order for the hospice consult? And the bone marrow transplant team says, well, our attending went in and the wife doesn't want to do hospice anymore. So we're going to try to get him down on the high flow nasal cannula, get his pain under control, and get him home. And the hospice and palliative medicine respondent says, okay, that's fine. I'm not the oncologist. I'm not the doctor who has a relationship with the family. And I'm not here to dictate my terms. I'm here to hear what's important. The wife tells me what's most important to us now, given these circumstances, is to be at home, for him to spend at least a few days with his brothers and sisters who are all coming in from out of state. Then I'm going to recommend what I think we need to do to achieve that goal. And then 2 days later, they call me back and they say, okay, we talked to the wife and they want to go home with hospice now. So we've decided to go home with hospice. And he died 4 hours later and he never got home. Right? And I use this anecdote to emphasize that reorienting patients and clinicians back to immediate achievable goals when there are ambiguous situations that result from the mismatch between how medicine tries to confront illness and its ultimate limit, that this is not a straightforward process. Essentially, that it is not the fact that clinical ambiguity can be addressed through translating between patients and clinicians by using this particular way of speaking is still quite complicated, because you're embedded in an organization and working with team members who might have a substantially different vision for how patient care should be conducted. And over the course of this process of articulating these particular research findings, I've discovered some rather interesting things. And on the whole, I think they're best summarized by some of the following quotes from my respondents. And essentially what I've been trying to say here is that there are these unique features of hospice and palliative medicine that I think that they've adopted to address some of these problems that are regularly produced by how medicine is organized. And despite this uniqueness, these clinicians claim that every physician should be able to do the same thing that hospice and palliative medicine does. That is to say, every physician should be able to talk to their patients and elicit some of their own patients' preferences. But not only that, not only should every other kind of clinician be able to do this, but that we should be teaching every other kind of clinician how to do this. And also that were other clinicians only to take the time to actually try to do this, they would be able to do it. And I can't spare the time right now to fully make the case, but to suffice to say that it is considered generally unsound to establish your medical specialty by saying anybody else could do this. It's not a very good way of establishing a unique domain of expertise that you are solely capable of dealing with. And I think that hospice and palliative medicine can be appropriately described as being a kind of generalist specialty. They're doing things that are foundational to medicine broadly, engaging patients in conversation, engaging them in conversations about what's important to them and how to achieve the goals that they have, and matching the full battery of technology that we have available to treating illness and injury to those goals. And I phrase this in terms of the specialization paradox, that this rationalization of medicine has become so sophisticated that now it has to produce, paradoxically, a specialty that is broad in its area of specialization. And as another promissory note for the future, this is essentially what the content of my book project is about. It's not only articulating this overall arc of this argument, but in particular, how this specialization paradox says something I think profound about how medical care is organized and how it produces these reliable failures in practice. And to end, I want to linger on death and dying as the fundamental motif that organizes both my own engagement in the study of medicine, but also this talk, and the unique features of mortality that make it the fundamental limit of medical efficacy. And that is that's these four different characteristics. It's inevitability, universality, irreversibility, and permanence. And despite whatever promises technological innovation offer us, I think that death will endure as the permanent limit of medicine's efficacy. And despite the quite substantial change or advances that medicine has been able to make in prolonging life, reducing morbidity, or compressing morbidity, and overall elongating human life, that this is an enduring problem. And medicine's not particularly good at failing. And I want to leave you with this quote, which is from the horror fiction writer Thomas Ligotti in his book, The Conspiracy Against the Human Race, where he writes, "Death would not be so bad if we could just disappear into it without any irksome preliminaries. For the rest of us, the carousel of consciousness spins round and round, enlightening us only to the blood-curdling probability that the worst will likely be saved for last." I think that this is a true description of death and dying because of the pain and suffering that it entails and the decisive moments of decision that it brings to us. But if anything, if I leave you with anything, then I want to leave you with the impression that I don't think medicine has to be a part of the problem, which is to say, it doesn't have to be part of the reason why the worst will be saved for last. And I think that clearly addressing how medicine's rationality produces indecision at the end of the life is one means of helping to prevent that. And so I thank you.